Hello everyone, welcome back to my YouTube channel Dr.Barki's Ophthalmology Tutorials. Today we will discuss about the orbital fascia. It's very interesting to know about orbital fascia because very beautifully it divides and organizes all the intra-orbital structures. Though it is a very minor structure, one needs to know about the orbital fascia to understand the various physiological aspects as well as the disease process of orbit in detail. Okay, so without much delay, let's begin our video on orbital fascia. So you can define this orbital fascia as a thin connective tissue membrane which lines as well as separates various intra-orbital structures. Okay. Though this orbital fascia is a single continuous structure, it can be divided into various parts just to understand this in a better way. Okay. So this orbital fascia can be divided into the fascia bulbi, the muscular sheath, intermuscular septum, extraocular muscle expansions and ligament of Lockwood. So coming to the fascia bulbi, it's also called as the Tenon's capsule. So this is the diagram which is showing the eyeball, okay, with the optic nerve, okay. So the eyeball and the optic nerve is situated in the orbital cavity. This thing which is shown in the orange color is the Tenon's capsule. So this extends from the margin of the cornea from the limbus and then lines the optic nerve and then merges with the dural sheath. So this is the Tenon's capsule. So this Tenon's capsule has two surfaces, as you can see. This inner surface is more well defined and it is attached to the sclera by fine trabeculae, whereas the outer surface is little ill defined and it merges with the conjunctiva in the anterior half of the eyeball. Okay. So up till here where there is conjunctiva, the Tenon's capsule will merge with the conjunctiva. Okay. If you come to the posterior part of the Tenon's capsule, that is this part is in contact with the orbital fat. Then if you consider the Tenon's capsule which is lining the optic nerve, that is in the anterior part as well as in the posterior part. So here, so if you see posteriorly, the Tenon's capsule is merging with the dural sheath of the optic canal. Okay. And in the anterior aspect of the Tenon's capsule which is lining the optic nerve, it is pierced by the optic nerve as well as the ciliary vessels and nerves. At the equator, it is pierced by the vertex veins. If you come more anteriorly, it is pierced by the muscles, that is extraocular muscles. This is how the Tenon's capsule is arranged around the eyeball as well as the optic nerve. And here in this part, as you can see, the lower part of the orbital fascia or the Tenon's capsule is thickened to form what is known as the ligament of Lockwood, which almost holds the eyeball in place. Okay, that is called as ligament of Lockwood. So to sum up the Tenon's capsule, from the anterior side it extends from the cornea and then covers the eyeball and then covers the optic nerve as well. In the anterior aspect of the eyeball, it is in contact with the conjunctiva on the outer surface, and on the inner side it is in contact with the sclera. In the posterior aspect, it is in contact with the orbital fat. Okay, and the Tenon's capsule which is lining the optic nerve merges with the dural sheath at the optic canal, whereas anteriorly it is pierced by this optic nerve, the ciliary vessels, vertex veins as well as the extraocular muscles. And inferiorly, the Tenon's capsule is thickened to form what is known as the ligament of Lockwood. Okay. So this is a diagram which is showing the Tenon's capsule again. So as you can see, the red thing which is lining the eyeball is the Tenon's capsule. There are two schools of thoughts regarding the facial sheaths of the extraocular muscle. Some say that it is a separate sheath which is covering the extraocular muscle. But the other one says that this extraocular muscle is piercing this Tenon's capsule so that the Tenon's capsule is lining the extraocular muscle like a glove. Okay. So that is the facial sheath of the extraocular muscle. So apart from that, there are facial expansions of these extraocular muscles. Okay. Into the facial expansion of the medial rectus and the lateral rectus muscle. So from the medial rectus muscle, the facial expansion goes and attaches to the lacrimal bone, leading to formation of medial cheek ligament. From the lateral rectus muscle, it is attaching to the zygomatic tubercle, leading to the lateral cheek ligament formation. So from the superior rectus muscle, the facial expansions will go to the LPS muscle and it is attached to the levator palpebrae superioris muscle. Because of this attachment, there is synergistic action of this LPS muscle with the superior rectus muscle. So whenever the superior rectus is put into action, whenever the eyeball is elevated, the upper lid is also moved up because of the synergistic action of this LPS muscle with the superior rectus muscle. And because of the same reason, whenever we are planning for the LPS resection in case of ptosis, if these fibers are not dissected properly, then we may end up with the hypotropia postoperatively. That is, the eyeball may be going down in the postoperative period. So it is very important to dissect the facial expansions from the superior rectus muscle to the LPS. If you come to the inferior rectus muscle, again it sends the expansion to the capsulopalpebral fascia, which is analogous with the LPS muscle. So that was about the facial expansions from the extraocular muscles. And one more important and interesting thing is, from the anterior aspect of all these facial expansions, few fibrous bands passes and get attached to the conjunctival cul-de-sac. So these connections will account for the retraction of the conjunctival sac when these muscles contract. That is, suppose medial rectus is contracting, there is no folding of conjunctiva on the nasal side because few fibers from these facial expansions are attached to the conjunctiva there, so that the conjunctiva is retracted and there is no folding or the overriding of the conjunctiva the medial side. Okay. Then coming to intermuscular septum, it is nothing but sheaths of the four muscle which are joined by each other by the facial membrane. Okay, this is called as the intermuscular septum, which is joining all the four muscles. And this intermuscular septum divides the orbital cavity and the orbital fat into the central as well as the peripheral part. Then coming to the periorbita, so the periorbita will be lining the surfaces of all the orbital bones. It is loosely attached all over except at the sites of the superior orbital fissure, inferior orbital fissure, optic canal, the orbital rim, okay, as well as the lacrimal fossa and the suture lines. At these points, the orbital fascia is very firmly attached to the orbital bones. At the optic canal, the dural sheath of the optic nerve is very closely attached to the periosteum, and anteriorly, if you come near the lacrimal bone, here the periorbita divides at the posterior lacrimal crest, then encloses the lacrimal gland, and then again unites at the anterior lacrimal crest. Okay, then gets firmly attached to the orbital rim. So this is about the periorbita. So hope this short video on orbital fascia and the periorbita is useful to all of you. So if you like my videos, please do subscribe to my channel. Press the bell icon for further notifications. Please do like and share my videos and leave your valuable comments. Thank you so much.